Hello, everyone, and welcome to our second lecture on alcohol and alcohol use. So we'll keep looking at alcohol today. We've already gone over the history last time, and today we'll talk about the effects of alcohol, what alcohol does both to the brain in producing behavior, and also the body in general. And we'll also go over the acute effects, that is the short-term effects of alcohol use, and the long-term or chronic effects. We'll also talk about trends in usage, um, and not just trends in usage, but also sort of the effects on society and what those trends are. How often is alcohol involved in certain kinds of crime or certain behaviors? So in particular, what we're going to do is try to understand how alcohol affects both the body and the brain. We're going to learn about what alcohol does to the body and the brain and how that produces behavior, how that alters our behavior when we consume alcohol. We'll also look at these trends in alcohol consumption, looking at things like the recent history of alcohol use over the last couple decades. We'll look at the effects of gender, and we'll talk briefly about the effects of culture internationally. So what happens when we consume alcohol? Well, obviously, like any drug, it's absorbed into the blood, and then it goes from there to the brain. Alcohol, ethanol, is a small molecule, and it doesn't really have much trouble passing the blood-brain barrier, so it goes to the brain pretty quickly. Um, it is primarily absorbed in the small intestine. A little bit will get in through the stomach, but mainly it's the small intestine, so alcohol has to make it that far through the digestive system before it's brought into the bloodstream. And the amount of alcohol in the blood is usually summarized by a measure known as the blood alcohol concentration, or BAC. Sometimes it's called the blood alcohol level, or BAL. And the relationship between the amount consumed and the eventual blood alcohol level depends on several factors. The most important are the gender of the person and the body mass of the person. So for a given amount consumed, sort of the bigger volume, that is, the bigger the person is, the more volume the person has to sort of dilute the alcohol. If you're a very small person, you only take up so much space, so that alcohol only has so many places to go. If you're a very large person, that alcohol can be dispersed across the entire body. And it depends on the sex of the person, mainly because women tend to have a higher percent body fat than men do. And so alcohol doesn't diffuse into fattier tissues as easily as muscle tissues and other organs. And so the higher the percent body fat of the person, sort of the less space, effectively, the alcohol has to go. So it depends on the sex and really the percent body fat, and it depends on the body mass. And both of these impact how wide an area, how big a volume the alcohol is dispersed over. And we see here in this table from your book, the amount of alcohol and the blood alcohol level that will result as a function of the mass of the person and their gender. So alcohol, when it's in the body, is eventually metabolized by the liver. And your liver can process about 1/4 of an ounce of pure ethanol every hour. So you'll notice here in the book, we have the smallest amount is 1/2 ounce. So your average alcoholic beverage, whether it's a beer or a glass of wine or a shot of a distilled beverage like whiskey or gin or vodka, those tend to have, on average, 1/2 ounce of pure ethanol in them. And that's why we talked about the alcohol content last time on each of the types of alcoholic beverage, because even though the alcohol content changes from one kind of beverage to another, that's compensated for by the average serving size. So if you have a 12-ounce beer or a 16-ounce beer, or half a glass of wine, or a single shot of a distilled alcoholic beverage, those on average have about the same amount of pure ethanol in them. So we can talk about things in units of drinks, where a drink is an alcoholic beverage that has 1/2 ounce of pure ethanol. Anyway, your liver can go through 1/4 of an ounce an hour, which means on average, it takes a person 2 hours to process every drink they consume. So what happens when alcohol is consumed? Well, alcohol is a depressant. And we talked a bit about it when we covered depressants and inhalants a couple of weeks ago. But obviously alcohol is a big enough topic that it merits its own unit. So alcohol is definitely a depressant. It's not like marijuana where it's a little fuzzy which category it belongs to. Uh, in addition to other properties, alcohol is a direct GABA agonist. That means it acts on the GABA receptor and enhances the effect of GABA. So that's why it's a depressant. It enhances the inhibitory um, effect in the central nervous system. But that's not all it does. And in fact, until very recently, how alcohol worked was almost a total mystery. And there are still some aspects of its function that remain unknown to a certain degree. So we know it also works on the dopamine system, serotonin. It's not clear exactly how these effects take place, but it's not just GABA. So we talked about depressants a couple weeks ago, and some depressants are very specific to the GABA system. Alcohol is not. So it's a depressant, and we talked, again, during our depressants unit, about anesthetics and how anesthetics are also depressants. And classically, historically, alcohol was sometimes used as an anesthetic. It was a way of knocking the person out so they didn't experience the pain of surgery. But it's not a very good anesthetic because the amount it takes to knock someone out is very close to the amount it takes to kill someone. So to induce a surgical level of unconsciousness, you need a lot of alcohol, and just a little bit more will stop the person breathing. So that's why it's not a very good anesthetic. It's very dangerous to use alcohol as an anesthetic, and as soon as other anesthetics were developed, people started using those. So it's a depressant, so we imagine that it's going to have many of the same effects that normal depressants do, and that's true. So for example, the effects depend on the dosage being consumed and on the level of the tolerance for alcohol the person has, but oftentimes a person will have cross tolerance. That's a concept we talked about a few weeks ago, where, for example, if someone develops a tolerance for morphine, they'll also probably be tolerant to codeine, even if they've never taken it before. Similarly, if someone is a heavy drinker or someone uses other depressants, they tend to have a tolerance for all depressants. But in addition to that, you see various behavioral effects that depend on how much alcohol has been consumed. And this is a concept that I'm sure many of us are aware of. So for example, at low doses, like other depressants, you get relaxation. So you get a little less motor activity. You also get this subjective sense of relaxation, which is why a lot of people have a drink every now and again, especially if they're stressed out. Um, it also has a disinhibiting effect. And it's not exactly clear why this happens. There are a couple of possibilities. So people will actually become more active early on with low doses of alcohol. It's a depressant, but it has this sort of paradoxical effect early on for low doses, and it's thought that perhaps that alcohol inhibits GABA neurons a little bit earlier, a little bit faster than other neurons. So very early on, you're inhibiting the inhibitory system, and before alcohol starts inhibiting everything, you get this moment or this period where only the inhibitory system is shut down, and so you actually get kind of an excitation effect. Again, it's not entirely clear why this happens, but that's one possibility. With increasing alcohol consumption, you start to lose motor control. So you lose balance and coordination, and movements become jerky and sweeping. Targeted movements become difficult. But there's also an effect of expectation, and we talked about this in the very first lecture. So even if somebody is given a placebo drink, that is a drink that doesn't contain any actual ethanol, but they're told that it's ethanol, they exhibit a lot of the same behaviors that somebody actually who's been drinking exhibit. So they'll have this disinhibition effect, for example. That's the most common one for this alcohol placebo. So the expectations matter. And of course, in our um, unit on tolerance, we talked about one form of tolerance, which is behavioral tolerance. And that's the case where someone who's experienced with a drug is able to exhibit fewer behavioral effects because they can anticipate the effects of the drug they've experienced with it. And alcohol is the same way. You can get fewer behavioral effects or less severe ones for people who are accustomed to consuming alcohol because they've developed that behavioral tolerance. They know what to expect, they're accustomed to those behavioral effects, and they can, to a certain degree, compensate for them. Of course, once you move into higher dosages, you can no longer do that. So some other effects at higher dosages are things like blackouts. So this is another acute effect, that is a short-term effect. And this is where the person loses memory. And it's not just because they pass out, they lose consciousness and don't remember. Someone can actually be conscious and functioning and then not remember what they did the next day. And again, we already talked about how depressants can affect memory, but this is a fairly common phenomenon with high levels of alcohol consumption. Somebody can be awake, can be upright, talking, moving around, and not remember it because they've lost the ability to consolidate memory. Of course, at even higher dosages, you get loss of consciousness. So in this way, alcohol is a classic depressant. You take enough of any depressant, you'll eventually lose consciousness. And naturally, you take even more than that, and you can get acute alcohol toxicity and death. And alcohol in sufficient quantities will suppress respiration. You'll stop breathing. So that's how alcohol in very high dosage can kill you. And that requires a blood alcohol content or concentration of about 0.4, which is really high. Most states have a legal limit of around 0.08. So you'd have to be at 5 times the legal limit to die. So in addition to behavioral effects, there are also, of course, physiological effects. So for example, alcohol will dilate blood vessels. It's a vasodilator. And then classically, people often drink alcohol on a cold night in order to feel warm. And in fact, you do feel warm. That's a subjective feeling, but of course your blood vessels are dilated. You're actually losing more body heat than if you hadn't been drinking. It's very dangerous. So if you're ever in a situation where you're in danger of hypothermia, whatever you do, don't drink alcohol. It'll only make it worse. That's why the classic painting of the St. Bernard with a little barrel of brandy beneath it is the last thing in the world you want to do for someone who's stranded in the freezing wilderness. It'll actually make someone develop hypothermia that much faster because you're just bleeding off body heat because it's dilating your blood vessels. One thing alcohol also does is decrease the effectiveness of what's called antidiuretic hormone, or ADH. And ADH is a hormone that causes your kidneys to take liquid back into the bloodstream. So if you inhibit ADH, what do? Well, you're no longer taking the liquid back in through the kidneys, and now you have more frequent and larger volume of urination. So that's one of the well-known effects of alcohol, and that's why it happens, because it interferes with antidiuretic hormone. But of course, there are other effects that aren't so immediate, that are still a result of alcohol. So for example, other complex behaviors like driving. And if alcohol interferes with simple behaviors, like motor control, like judgment, obviously it will interfere with complex behaviors as well. So driving under the influence of alcohol. Obviously there's an effect of the amount of alcohol in the system. So at around 0.08 blood alcohol concentration, you're about 3 times as likely to have a fatal car crash as if you hadn't been drinking. At 0.1 or above, those odds increase. And this, again, depends a little bit on the experience of the drinker. That is to say, someone who's used to consuming alcohol, the risk is a little bit less. It's around 3 times. Um, but if someone's inexperienced, that risk can be 5 times the normal fatality rate for an inexperienced drinker. And we see here on the right a graph in your book uh, that is the proportion of alcohol-related fatalities and car crashes since the early 80s. And as we can see, this is decreasing, which is good. The number of non-alcohol-related fatalities is more or less the same. There's been some improvements thanks to things like safety mechanisms. Um, but the incidence of fatal crashes involving alcohol are actually have been decreasing since the early 80s. So one thing about demographics, so men are more likely to be involved in a car crash involving alcohol, fatal or otherwise. We'll talk about more about why that is in a bit. Um, but it's also, there's a stereotype that really it's just the problem drinkers, the chronic drinkers who are causing the car crashes. Someone who's been chronically abusing alcohol for years is the sort of person who gets in a fatal car crash. And actually, sure, problem drinkers do account for more than their fair share of alcohol-related car crashes, but the vast majority are still individuals who have never been in trouble for drinking and driving. So anyone can, if they drink, anyone is at an increased risk at being in a car crash, even a fatal car crash. So it's not just chronic abusers of alcohol. Of course, another famous effect of alcohol is its effect on sexual behavior. And this is part of its disinhibiting effect. So part of it is expectations. Again, you can give someone a placebo drink and they will exhibit the same increase level of interest in sexual activity. They'll be more disinhibited. They'll engage in riskier sexual behavior. Um, but alcohol itself seems to generate this behavior also. So it's sort of a mixed bag of the actual effects of alcohol and the effects purely of expectations. One interesting psychological effect is actually from a third-party standpoint. Of course, alcohol is the most common drug involved in things like date rape and other forms of sexual assault. We talked about GHB and Rohypnol in our unit on depressants, but the fact is that alcohol is far and away the most common drug involved in sexual assault and date rape. But if you query people about how blame should be assigned, who's responsible for the sexual misconduct, um, the alcohol, the presence of alcohol in the perpetrator and the victim has an effect on who's perceived as being to blame. Um, if both parties have been drinking, the perpetrator is viewed as being less responsible, and the victim is being viewed as relatively more responsible. Not more responsible than the perpetrator, just more responsible than a victim who hasn't been drinking. Um, so that's a well-known effect, and obviously that's a social problem, but that's not a direct result of alcohol. That's a social effect of alcohol. And finally, getting to other forms of criminal behavior, alcohol is commonly involved in both homicides and suicides. It's estimated, depends culturally a little bit, but it's estimated that about half of homicides involve alcohol consumption, and that around a third of suicides involve alcohol consumption. But it's difficult to determine whether alcohol is actually the cause. So, for example, it's been shown that a high proportion of homicide victims have alcohol in their system, but that doesn't necessarily mean that the killer was drinking or that alcohol was to blame. Also, you can have a common cause for both the criminal behavior and the alcohol consumption. So, people that are in dysfunctional relationships. The dysfunctional relationship itself can increase the incidence of drinking and can increase the likelihood of domestic violence or other criminal behavior. So is the alcohol to blame, or is it a symptom just like the violence is? It's very hard to say. There are also other social situations. I believe your book cites the example of a group of men in a bar. If there's a fight, is it the alcohol that's to blame, or is it the fact that if you put a group of men together in any situation, that a fight is more likely than not? So these are all very difficult issues to try and parse out statistically, and of course it's not ethical to run an experiment to see if someone will engage in criminal or violent behavior as they consume alcohol. So a word on alcohol toxicity. So obviously this is the result of the acute and rapid consumption of alcohol. So normally the body will respond to many toxins, and alcohol is one of them. If it's sufficient in quantity in the body will respond by vomiting, trying to expel that toxin. But unfortunately, if the alcohol is consumed too rapidly, or if the person vomits and then continues drinking, if you have a blood alcohol concentration above around 0.2, then you actually start to inhibit that vomiting reflex. So it's very dangerous to consume alcohol very rapidly. It's very dangerous to continue drinking after the onset of vomiting, because you'll no longer be able to expel the alcohol that you're consuming. A quick word about alcohol toxicity before we move on to hangover. Um, if you run into someone that has had too much to drink, um, if they're at the point where they are passed out, do not assume that they're simply going to sleep it off and be fine. Um, blood alcohol poisoning is not a very common cause of death, but it does cause about 1,000 deaths in the United States every year. Um, and so many college campuses will have, and medical centers will have sort of amnesty policies where you won't get in trouble if you bring someone in or if you yourself have been drinking to excess, um, that there are sort of safe haven rules. So don't be afraid to help someone who's in need or to report to a hospital yourself if you or the other person has consumed too much alcohol. So after someone's consumed a large amount of alcohol, they often have a hangover the next day. And hangovers are a little mysterious as well. It's not exactly clear what causes them. The symptoms are pretty common. You have things like nausea, headache, general fatigue, um, dizziness, and it's not entirely clear what causes hangovers, if it's any one thing. It may be fluid loss. So as I mentioned, alcohol inhibits the effect of antidiuretic hormone, so you tend to expel more fluid, so you end up dehydrated. Of course, that throws off the balance of electrolytes in your body. It can also be a reaction not to the alcohol itself, but to the other ingredients in the beverage, the congeners in the case of distilled beverages. A common theory is that it's actually a reaction not to the ethanol, but to the metabolites of ethanol. So your liver turns ethanol into acetaldehyde, which then gets, in turn, converted to other chemicals. But acetaldehyde is actually more toxic than alcohol is, but it's usually processed so quickly that there's not as much of it present in the blood as there is ethanol. If you've heard of the drug antabuse, so that is a drug for treating alcohol dependence. And the way it works is if someone is on antabuse and they consume alcohol, they will very quickly become nauseous and sick. And the reason that is because what antabuse does is it keeps acetaldehyde from being converted into the other metabolites that the liver converts it to. So acetaldehyde will start to build up in the system, and that's what actually makes the person nauseous, because the metabolic pathways in the liver have been disrupted. So it's not the alcohol, it's the metabolite of alcohol that's causing sickness in that case. Again, it's not entirely clear whether it's entirely responsible for hangovers, but it is thought to be at least partially responsible. And of course, for the nausea and the stomach ache, alcohol itself is a gastric irritant. It irritates the linings of the stomach. So it's no surprise that that's one of the symptoms involved in a hangover is a feeling of nausea and stomach upset. So for the chronic effects, the long-term effects of repeated alcohol use, um, there's of course a level at which the brain itself is damaged. And you can see this in the brains of chronic alcohol users. So you can see a shrinkage of the brain, a decrease in brain volume. And this can lead to things like alcoholic dementia, which is just a general form of dementia, which is a loss of intellectual function, usually a loss of memory, loss of awareness brought on by alcohol. There's also Wernicke-Korsakoff syndrome, um, which is another possible outcome for chronic alcohol abuse, the most famous symptom of which is what's called Korsakoff psychosis. And what that is, that's a loss of memory, but the most interesting aspect is that unlike other forms of memory loss, where someone acknowledges that they can't recall information or are aware of the problem, someone with Korsakoff's psychosis will do what's called confabulate. And that means that if they can't remember something, they will make up a story that makes sense given their current circumstances. And they're not aware of it. They're not aware that they're making up a memory, in effect, but that's what they're doing. So it's a form of memory loss that, again, occurs with chronic alcohol abuse. There are other effects on health, of course, as well, the most famous of which is cirrhosis or scarring of the liver. And it takes a long time and heavy use of alcohol for this to happen. I think your book points out that it takes about a pint of distilled spirits a day for a period of around 10 years to get severe cirrhosis. And that's where you get scarring in the liver. Liver no longer functions like it's supposed to, so you can't actually process alcohol as well. So it exacerbates itself. It makes the problem worse because the liver can no longer process alcohol as well, and then alcohol is that much more toxic because it's not being processed, and it's sort of a feedback loop. By the way, cirrhosis will be one of the topics for discussion this week, so look for that. Alcohol has also been implicated in heart disease, and sort of like caffeine, there's some evidence that mild amounts of alcohol can actually be beneficial. There have been studies for 10 years or so on the possible beneficial effects of particularly red wine. But of course, heavy alcohol use increases the risk of heart disease, just like heavy caffeine use increases heart disease, but a little bit may be beneficial. There's also cancer, particularly cancers of the digestive system. So all the way from the mouth, the esophagus, the stomach, the colon. All of these cancers are increased by heavy alcohol use. In terms of reproductive effects, the most famous and most severe is what's called fetal alcohol syndrome. And here we have a picture of an individual, a child with FAS, or fetal alcohol syndrome. And this has a couple of symptoms. Not everyone expresses all of them. In fact, all you need is one to qualify, but it usually involves one of the following. Retardation of growth, so the person is physically smaller. You also have sort of characteristic facial features. You have a shorter bridge of the nose, a flatter bridge of the nose. You have a smaller head. The eyes tend to be smaller. So these are all consequences of alcohol consumption during pregnancy. The third effect is just general mental retardation, so cognitive effects. And again, any or all of these could occur in an individual with fetal alcohol syndrome. Now, again, with chronic use, as with other drugs, we have the concept of alcohol dependence. So talking about withdrawal symptoms. So dependence, one of the hallmarks of dependence is the presence of withdrawal symptoms. That's what characterizes physical dependence. So what are the withdrawal symptoms like? Well, they come in a variety of stages. And the early ones, if someone is used to chronically consuming large quantities of alcohol and stops, often the early symptoms are tremors, so that is shaking of the hands in particular, and insomnia. so the inability to sleep. Following that is the onset of hallucinations or delusions. Hallucinations are, of course, sensory perceptions of things that aren't there, whether it's visual or auditory. Delusions are false beliefs. So these are both symptoms that are present in schizophrenia. Uh, we also have seizures in someone who is dependent on alcohol. Now, what you do is, if you look at these symptoms, compare these symptoms to what depressants do. So depressants are used to alleviate insomnia. They're used as anticonvulsants, that is, to reduce the incidence and severity of seizures. So again, we see this idea that the body and the brain have become used to the presence of the drug, in this case alcohol, and so as soon as you remove that drug, the body is now overcompensating, right? It's compensating for a drug that isn't there. And so you get insomnia because the body is used to alcohol, a depressant, aiding with sleep. And you get seizures because the body is again used to alcohol being present and suppressing motor activity and seizures. So just like other depressants, we see that if someone's dependent and they're taken off them, you get a lot of the symptoms that depressants are usually used to alleviate. As for the hallucinations and delusions, alcohol does affect the dopamine system, and so in addition to the serotonin system, and so we see some of these symptoms of schizophrenia, possibly, it's not for certain, because of its effects on the dopamine system. So how is alcohol dependence treated? So first, withdrawal is actually physically dangerous. For example, heroin dependence, if you are dependent on heroin and you suddenly stop, there are some negative symptoms, to be sure. It can be very unpleasant for a few days. But actually, for someone who's dependent on alcohol, suddenly stopping can be very dangerous. These seizures can be fatal. So it's usually better to sort of wean someone off or to substitute a non-addicting, or at least a less addicting, depressant for alcohol, something like a benzodiazepine. These are often used in treatment for alcohol dependence. So you're substituting a different depressant, and then you wean them off of both depressants gradually. Of course, the most famous behavioral treatment program for alcohol dependence is Alcoholics Anonymous. And this is a program that's famous for having 12 steps. It's famous for certain religious overtones. And your book actually has a little discussion box about whether Alcoholics Anonymous is a religious organization or not. And so you have these 12 steps, and you also have Alcoholics Anonymous is an organization that introduced the concept of alcoholism as a disease. Now, we've already had a question about this, whether alcoholism or other forms of drug use are diseases. They share some characteristics, but not others. But the main point of the disease model seems to have been a destigmatization of alcoholism. Again, trying to get away from the moral model of alcohol abuse and moving toward a disease model, even if alcoholism is not in all ways a disease. So what puts someone at risk for developing alcohol dependence? Well, there are genetic factors. So twin studies have revealed that if one identical twin is dependent on alcohol, there's a much higher likelihood that the other identical twin will be dependent as compared to a fraternal twin, for example. So there are genetic factors. It does seem to run in families in certain cases. There are also cultural factors. So certain cultures, your book points out Russia and Ireland, are famous for heavy use of distilled beverages, as opposed to regions around the Mediterranean, which are things like Spain, places like Spain and Italy, which are more famous for consuming wine and consuming that in a family environment at meals, as opposed to sort of night bar-based drinking culture at night, where there are lots of distilled spirits that are consumed. And these are influences. these cultural influences give us norms. What is expected of us, in terms of our behavior? What is acceptable in terms of our behavior? And so we see genetic and environmental influences um, on alcohol dependence and rates of alcohol dependence. Okay, so in terms of trends in alcohol consumption, we have these cultural differences, uh, not just in terms of where and under what circumstances drinking occurs. Is it at mealtime? Is it in the morning? Is it at night in a bar? You have differences across what beverages are preferred. So you have some cultures that prefer wine, some that prefer beer, some that prefer distilled beverages. And so culture can heavily influence how acceptable different drinking behaviors are. How much alcohol is it acceptable to consume in a social setting? How how early is an individual allowed to start drinking in terms of their age? In the United States, we have some fairly clear trends. So, for example, over time, over the last couple of decades, we've seen a decrease in the amount of alcohol consumed, particularly the amount of distilled alcoholic beverages. So these things, the overall amount of alcohol consumed in the U.S. peaked in the late 70s, reached a minimum in the late 90s, and now it's a little bit higher than it was in the late 90s, but not nearly as high as it was in the late 70s. So right now, we're on the lower end of alcohol consumption in the U.S. There are also gender effects. So males tend to drink more frequently and tend to drink more in a sitting uh, as compared to females. And this also influences things like drinking and driving statistics. So most drivers that are uh, involved in accidents uh, under the influence of alcohol tend to be male. Um, there are a number of factors involved in this. So men tend to drink more and more often than women do, but they're also more likely to be drivers. And they're also more likely to engage in risky behavior anyway. So being involved in alcohol-related car crashes, it's not all that surprising that it's more common in men than women, but there are a variety of factors involved that we have to keep in mind. There's also an effect of age. Obviously, college-age students in the U.S. Tend to have a high level of alcohol consumption relative to their high school peers and relative to older adults, certainly. So we see these trends um, over age groups. We also see them across different states. So as your book points out, alcohol purchases, which is displayed here in this graph, is actually highest in New Hampshire, but that's a little bit misleading because apparently a lot of people are buying their alcohol in New Hampshire than driving back to their home state. New Hampshire has low taxes on alcohol, so we shouldn't take this to mean that alcohol consumption is higher in New Hampshire um, or in Nevada for that matter. So we have to be careful. Again, we have to examine where our statistics come from and what they're actually measuring. So we see lower alcohol consumption in the Midwest. It is higher in the Pacific Northwest on average. And again, it's also higher in the Northeast. So we see this geographic variance as well. Okay, so that wraps up our unit on alcohol and alcohol use. Next time, we're going to look at tobacco, which is another very popular drug. Obviously, it's another natural product, so it's going to have a long history. Um, so we'll talk about that history, the history of tobacco cultivation, its impact on society, on the economy. We'll try to understand how tobacco works, and in particular how nicotine works, which is the primary active ingredient in tobacco. And of course, some of the effects are well known to the average person, but some of the effects you may not know. So we'll go over what nicotine does at the individual level. And we'll talk about that next time. So I will see you then.